My name is Nageshwar D. I'm a gastroenterologist and chairman of AAG Hospitals at Hyderabad, India. We are a large pancreatic center and we get a large number of acute necrotizing pancreatitis, and around 300 of them actually land up with us with the walled-off necrosis. Many of these patients, when they require drainage, they're done endoscopically using endoscopic ultrasound guidance. And over the last few years, we've been using either a metal stent or a plastic stent in these patients to drain this necrotic material. Recently, there's been a randomized controlled trial from our center titled Biflanged metal stents versus plastic stents in endoscopic ultrasound guided drainage of walled-off necrosis, a randomized controlled trial. It was published in Endoscopy, and I have with me the first author of this article, Dr. Krithi Krishna, who is a consultant at AAG Hospitals. Krithi?
Hello. So this stent, the biflanged metal stent, which is known as the Nagi stent, was actually designed by my teacher, Dr. Nageshwar D. This stent is available in different sizes and it has two flanges. So these flanges prevent the migration of the stent. For our population, this stent is a cost-effective alternative as compared to the other stents available. At the time of conducting this study, there was not enough data to show the superiority of metal stents or plastic stents in the EUS-guided wand drainage. So there were only two published RCTs, none from India and none with the BFMS. So this motivated us to do this study.
So, Krithi, what is the outcome of this study and why is it important?
We found that both sets of patients have similar clinical success at 1 month, that is around 90%. However, in the BFMS group, 13 patients required 25 reinterventions, whereas in the plastic stent group, 24 patients underwent a total of 48 reinterventions. So, this means that the reintervention free clinical success, that was the primary objective in this study, was 67.4% patients in the BFMS group had reintervention free clinical success as compared to 43.5% patients in the plastic stent group. So, this implies that even though the initial cost of the stent may be lesser, because of the number of reinterventions, there is increased delayed cost and there is delayed recovery of the patient. So we also found that the duration of hospital stay was more in the plastic stent patients as compared to the BFMS. Now, one can argue that the overall clinical success is same in both the groups, but this is because a standard step-up approach is followed. So, if the patient does not respond, another intervention is anyways done. Now, there are a number of prospective and retrospective studies that have shown the superiority of LAMS. The first published RCT from Orlando found similar success in both treatment arms. However, the number of reinterventions, when analyzed, was significantly more in the LAMS group as compared to the plastic stent group. That is 75% versus 45%. Also, the Denmark group had done another study in which they had done weekly dilatation of the plastic stent group. So this again emphasizes that a larger tract is required for appropriate and adequate drainage of the wand, which means that a BFMS or a LAMS would probably do better even theoretically.
So, Kriti, now that this study is done, what are the next steps?
Yes. So in this study, we could not analyze the cost. So this also needs to be analyzed and we need more multi-center study. Based on our findings, we would like to consider the BFMS or the LAMS as the first line in wand drainage. Thank you.